2,000 students, so there are probably 8 heterozygotes for this severe and serious metabolic disorder. It's caused by mutation of the gene encoding LDL receptor or gene encoding ApoB mostly. The frequency of homozygotes is 1 in 1 million. When measuring blood lipids, total cholesterol is usually higher than 9, and LDL cholesterol the most atherogenic parameter is above 7.0 millimoles per liter. In homozygotes, total cholesterol is sometimes even 20 millimoles. You can see some symptoms in these individuals. They usually have tendinous xanthomas, mostly Achilles tendon xanthomas here, or on extensors of extremities like elbows or knees. They may present xanthelasma, and they may also have arcus lipoides cornea. These are the typical features seen in these individuals. Remember that this metabolic disorder is associated with extreme cardiovascular risk, represented by coronary heart disease, cerebrovascular stroke of ischemic origin, or peripheral vascular disease of the peripheral arteries. Drug of first choice are always statins. You can add ezetimibe, and when not achieved the therapeutic goal, you would add PCSK9 inhibitors. This is the modern therapy, the biological therapy, and we will talk about it later in this seminar. Resins have limited use because their tolerance is very limited. The patients have usually side effects like nausea or vomiting or stomach ache, sometimes constipation. In homozygotes, pharmaceutical therapy is mostly useless, and you have to send the patients to LDL apheresis. As I said, the defect is either in the binding domain of the LDL receptor, or there is a defect in the ligand, which is the ApoB100 in this LDL particle. ADH-PCSK9, this is autosomal dominantly inherited disease. It's now very popular to talk about this PCSK9 inhibitor because the modern biological therapy is directed towards this protein. However, there are patients with higher expression of this PCSK9, which leads to increased degradation of the LDL receptor and impaired LDL clearance from the plasma. This is the normal cycle of the LDL receptor that binds the LDL particle, and then in endosome it disconnects from the particle and returns back to the surface of the cell, mostly hepatocytes, where it can bind LDL particles again. However, in overproduction of the PCSK9, this is not possible because the PCSK9 blocks the disconnection or leads to degradation of this entire complex together with the receptor in the lysosome. Sometimes you may find in the literature autosomal recessive hypercholesterolemia. It's very rare. I don't think you need this right now for your state exam. The only therapy is LDL apheresis. What is, however, more important is the primary polygenic hypercholesterolemia. This is the most common isolated hypercholesterolemia in our population. There is again some genetic background, and together probably higher intake of saturated fat also participates in the manifestation of this disorder. The patients do not have such high levels of total and LDL cholesterol as you saw in the monogenic familial hypercholesterolemia, the heterozygous of familial hypercholesterolemia. Here, LDL cholesterol never exceeds 7 millimoles per liter. There is no clear familiar link in genealogy, and as I said, probably saturated fat in the meat and meat products are also responsible or contribute substantially to the manifestation of this polygenic hypercholesterolemia. These patients may have xanthelasmata on their eyelids, but never present tendinous xanthomas on Achilles tendon, nor arcus lipoides cornea, maybe later at their age, but not at the age of 20 or 30. However, you are right, there is an increased cardiovascular risk indeed, so we will start statins again, and here the therapeutical goal is easier to achieve. The response to the therapy in these individuals, together with dietary intervention, is more effective. If statin in maximum dose monotherapy is insufficient, then you may add ezetimibe, and in patients, especially in high risk, means patients, for instance, after myocardial infarction, you may also add PCSK9 inhibitors, the biological therapy. Residents, as I said, are almost out. Hyperlipoproteinemia. This is a lipoprotein that really resembles the LDL particle. It's very similar. The major structural apoprotein is also ApoB100, but there is additional polypeptide called Lp(a), and this is constituted by these so-called kringles of amino acids, and one type of these kringles, type 4-2, has homologous structure to plasminogen, and this leads to the competitive inhibition of plasminogen conversion to plasmin, and uh, and subsequently to uh, to impaired fibrinolysis on site of accumulation of this lipoprotein. It's produced in the liver, however, its physiologic function is not clear. It is associated with higher cardiovascular risk. However, there are no data from randomized controlled trials so far that lowering this Lp(a) would also have some impact on cardiovascular morbidity and mortality. However, we recommend, and European as well American guidelines recommend, measuring this Lp(a) in all patients at higher cardiovascular risks with positive family history, with a cluster of other cardiovascular risk factors, and in patients of secondary prevention. In individuals with Lp(a) increased over 400 nanomoles, it should be considered as risky as in patients with familial hypercholesterolemia. So you should treat these patients with statins and PCSK9 inhibitors to achieve the goals similar as it is in patients with myocardial infarction. That means lower LDL cholesterol below 1.4. I will speak about the goals in 15 minutes. Statins, however, do not lower Lp(a). The only thing you can do is add PCSK9 inhibitor, the biological therapy. What also helps is LDL apheresis in some centers can be performed. Now we are proceeding to another situation when not only cholesterol but both cholesterol and triglycerides are elevated. Familiar combined hyperlipoproteinemia is indeed the most common primary hyperlipidemia in our population. It's caused by inherited VLDL overproduction and conversion to LDL, so both VLDL and LDLs are elevated. The patients usually have total cholesterol between 5 and 10, and triglycerides usually varies between 2 and 9. They have, interestingly, no visible markers of hyperlipidemia, no xanthomas, no arcus lipidase corneae, but they do have higher cardiovascular risk. Always start giving statins and try to handle the increased triglycerides with diet. what can increase what can help is increased consumption of omega-3 fatty acids or fish oil that lowers triglycerides. When dietary recommendations and weight loss in obese individuals is insufficient, then you may add fibrate in cases when triglycerides are still over 2.3. Combination statin and fibrate is also recommended. You may also add PCSK9 inhibitors. There is another, this hyperlipidemia or dyslipidemia that is characterized by elevation of both cholesterol and triglycerides, and that is familiary beta lipoproteinemia, FDBL. This is a disease that is caused by mutations of the gene encoding apoprotein E. There are three apoprotein, three gene variants, epsilon 2, epsilon 3, and epsilon 4. The physiological variant is epsilon 3. Epsilon 2 and epsilon 2 in homozygote form is the predisposition of developing this beta lipidemia. However, remember that not homozygotes must immediately or essentially at the age of 20 or 30 develop this beta hyperlipidemia. There must be some additional genetic factors that may contribute to this disease. However, what triggers some exogenic factors triggering this beta lipidemia is obesity, diabetes, and alcohol. Cholesterol is usually between 7 and 10, triglycerides also sometimes up to 10 millimoles per liter. And when you measure the blood lipoproteins, IDLs, the intermediate density lipoproteins, and chylomicron remnants are elevated. These patients do have some symptoms. They may have a very rich tuber eruptive xanthomas on their thighs, on their buttocks, on their elbows. Sometimes they have palmar xanthomas in the palmar lines. May be typically have typically brown color. These patients are also at higher cardiovascular risks, and also you may use first statins, and if insufficient, then you may add fibrates. Statins and fibrates also in combination. Now we have the situation when only triglycerides are elevated. This is the primary hypertriglyceridemia. It's autosomal dominant inheritance with frequency 1 in 500, and it's caused by increased production of VLDLs in the liver. However, these are not converted to LDLs, so it all got stuck in the VLDL fraction. And as you remember, VLDLs transport mostly triglycerides. These may be up to 10 millimoles per liter. These patients may have eruptive xanthomas again on the thighs, in the gluteal region, or on their elbows. And when at higher cardiovascular risk, and when there is some family history, You should measure also LDL cholesterol and try to achieve the goal according to the guidelines. However, how to intervene triglycerides? You are right. Statins are mostly for cholesterol. However, triglycerides are just marginally influenced by statins. So in this case, you would probably have to give fibrates. The only thing in fibrates is that fibrates are not associated with such lowering of or such decrease of cardiovascular morbidity and mortality as statins are. However, in patients with triglycerides, despite dietary and physical activity interventions are above 2.3, you would probably have to add fibrates. Primary hypercholesterolemia is a rare disease, 1 in 1 million, and it's the genetic defect of lipoprotein lipase or its cofactor, which is ApoC2. These patients may have 100-fold increase of triglycerides. They have hepatosplenomegaly and splenomegaly. These organs are filled in with foam cells, and the only therapeutical option is decrease dietary intake all the way down to 15 grams of fat per day and increase omega-3 or N3 fatty acids in fish. These are the eruptive xanthomas you can see in patients with severe hypertriglyceridemia on their elbows or thighs. The basic lipid parameters may help to make the first, let's say, diagnostic classification. If only cholesterol is elevated, then it may be familiar or polygenic cholesterolemia. If cholesterol and triglycerides, then it's combined hyperlipidemia, mostly the FCH. It's the most common lipid disorder, primary lipid disorder, or this beta. And if triglycerides are elevated, then it's mostly primary hypertriglyceridemia. If there is no secondary, if there is no primary cause, and if it's not a secondary hyperlipidemia due to another primary disease. The secondary hyperlipidemias are shown here, especially alcohol, high triglycerides, but also cholesterol. Sometimes patients after alcohol intake may come with increased triglycerides over 30 millimoles and also cholesterol, and these are at high risk of acute pancreatitis. Remember that all patients with triglycerides above 10 millimoles per liter are at high risk of acute pancreatitis. I will explain it to the guy who was asking at the end of the seminar. Hypothyroidism, diabetic dyslipidemia is also very common in both type 2 and type 1. Hypercorticalism, corticotherapy in patients treated with steroids. Hormonal contraception, not all women, but those with some inherited sensitivity may develop combined hyperlipidemia on hormonal contraception. Nephrotic syndrome, severe proteinuria in this situation is typically associated with high cholesterol and triglycerides. Sometimes in acute hepatitis, sometimes in lymphomas, leukemias, or monoclonal gammopathy like plasmacytoma. In patients with autoimmune rheumatic disease like systemic lupus erythematodes, or rheumatoid arthritis. HIV therapy, the protease inhibitors, some of protease inhibitors are associated with high triglycerides and cholesterol. Anorexia nervosa, some girls come with this psychiatric disorder and have high cholesterol. This is the very common secondary dyslipidemia, so-called diabetic dyslipidemia, which may be a topic in your, or you may be asked about it during the state exam. This is associated with high triglycerides, represented by increased large VLDL particles that are in large amounts secreted from the hepatocytes to the bloodstream, and they are converted to the small dense LDL. So when measuring the basic lipid parameters, you would have typically elevated triglycerides and low HDL cholesterol, but LDL cholesterol would be normal. But when you look at the size of the LDL particles, the most atherogenic particles, these are very small. So the cholesterol within the LDLs is dispersed in more small particles, and you may help, or what may be of help is measuring of the ApoB, because you know that ApoB is the major structural apoprotein of the LDLs. So it will be associated with increased ApoB in these individuals. So typically, high triglycerides and low HDL, LDL cholesterol per se is normal or just slightly elevated, maybe, but when you look at the size of the LDL particles, these are small in diabetic dyslipidemia, and this means that these are more atherogenic, and they are easily oxidizable and may cause more harm in the arterial wall. And it depends on the compensation of dyslipidemia, of diabetes. If you have a good diabetes compensation, and if you achieve some, in especially diabetes type 2, lose weight, a loss of weight, and increase physical activity, and after some dietary intervention, this may be of help. These patients are definitely at higher cardiovascular risk. So these are the you may remember it. You have these guidelines, probably you have had these guidelines before. So in obese patients, always look at the caloric intake and try to achieve weight reduction. Fat total should represent 25 to 35% of total calories, and especially lower saturated fat below 7%, or so maximum 7% of total calorie intake. Out of these 30%, 10 should be represented by polyunsaturated fatty acids, and monounsaturated fatty acids, again 10%. Trans fatty acids should be below 1% without processed fatty acids. Sometimes in some sweets, some biscuits, but the amount has been very limited by the producers. Cholesterol per se should be lower than 300 milligrams per day. carbohydrates or saccharides, better say saccharides, 50-60% of total caloric intake, and 15% should be represented by proteins. Fibers, they are very good in lowering cholesterol, 30 to 40 grams per day, so cereals, vegetables, nuts, fibers are very good. Alcohol, please remember that now, according to the latest guidelines, 10 grams for both men and women. The movement Me Too has achieved that even for men, the highest recommended amount of alcohol is 10 grams per day. Phytosterols, the plant sterols do have some effect on lowering cholesterol, but they usually do not, or there is no proof that they have effect on cardiovascular morbidity and mortality. So these are the functional foods: fibers lowering cholesterol, phytosterols lower cholesterol but no effect on the heart epidemiological data. Omega-3 fatty acids, 3 to 4 grams per day, decrease mostly triglycerides and elevate cholesterol, and elevate HDL cholesterol. So hyperlipidemic drugs for cholesterol always start with statins, which are very good. If statins are not enough, then you would add ezetimibe and then PCSK9 inhibitor. Triglycerides lowering can be achieved by fibrates, but they do respond to some diet. As I said, this is what you know from Degas, so I don't think you have to go through it again. Remember that statins, in some, let's say 7% of patients on statins, they may develop muscle ache. So ask them if it's bearable or not. If they cannot tolerate, then you have to discontinue the statin therapy and try a different statin, like change atorvastatin for atorva, or atorva for Rosova, or vice versa. Always measure in patients with myopathy or with muscle ache, always measure creatine kinase. If it's above 10, it is more than 10-fold upper limit of norm, you should stop statin. And always ask whether the patient had some exercise, or whether he has hypothyroidism, and whether he is on low vitamin D. You should measure this as well. If the patient has only CK elevated 4 to 10-fold of the upper limit of norm, and the myalgia are not severe, then you may continue the therapy. Ezetimibe can be added easily to statin, and you can see that there is some additional effect on LDL lowering. PCSK9 inhibitors represent biological therapy, which is also available now in our country and in all European countries now. This is based on blockage of the PCSK9 protein that controls the expression of the LDL receptor on the hepatocyte surface. When you block this receptor by monoclonal antibody, the LDL receptor can disconnect from the LDL particle and the endosome and return back to the hepatocyte surface and again participate on LDL cholesterol clearance or LDL particle clearance. This is represented with additional 60% reduction of LDL cholesterol, and it has been approved by studies by clinical trials Odyssey or Fourier that PCSK9 inhibitor therapy is associated with decreased cardiovascular markers and mortality. Results are out. Fibrates only in patients with triglycerides, as I said, still despite dietary intervention above 2.3. Lomitapide in our country, it's only reserved for patients with familial hypercholesterolemia for the homozygotes. It may be added to their apheresis therapy, and it's a drug that blocks the microsomal triglyceride transfer in the liver and synthesis of VLDLs and chylomicrons. Now we are proceeding to the end. Before starting therapy, you have to assess the risk group of each patient: very high risk, medium risk, and low risk. In the very high risk group are those patients who already suffered from cardiovascular disease based on atherosclerosis, like coronary heart disease, cerebrovascular stroke, ischemic cerebrovascular stroke, or peripheral vascular disease. And in these individuals, I would like you to remember this number. The primary goal for LDL cholesterol, which is the primary goal for diagnosis and therapy in patients with hyperlipidemia, is below 1.4 millimoles per liter, and together more than 50% the reduction of LDLs compared to the initial initial levels. So in a very high risk group, it should be below 1.4. In patients with high triglycerides and with when triglycerides are above 2.3, you may use non-HDL cholesterol, which this is the parameter that represents cholesterol associated with all atherogenic lipoproteins, and then the number is 2.2 millimoles per liter. Remember, HDL cholesterol and triglycerides are not therapeutical goal anymore. However, there are still traditionally given these numbers below 1.7 millimoles per liter in triglycerides. And in men, the HDL cholesterol actually is not a typical, or is not a goal anymore. However, in patients with too low HDL, there are at high risk, but increasing HDL therapeutically hasn't shown any impact on cardiovascular morbidity and mortality. And in patients with high triglycerides, high levels of VLDL cholesterol, patients with diabetes, and obese patients, sometimes, or some guidelines say, or the recent guidelines, European guidelines from last year, say that better than LDL cholesterol is measuring the parameter non-HDL or ApoB. Non-HDL we had here, 2.2, and ApoB should be in the very high risk group, below 0.65 grams per liter. Remember, I told you in diabetic dyslipidemia that they produce those small dense LDL, and the number of ApoBs or the concentration of ApoBs nicely reflects the production of these small dense LDLs. So that's all, and I can see that there are some questions. First from Ifracondra in regards to primary polygenic hypercholesterolemia in diet high in bad fats, lots of red meat, butters, and worse than, for example, eating eggs every day. I feel like that there's a good information of whether eating eggs is bad or good. Thank you. Thank you for the question. Very good question. This has been revised recently. You may eat, let's say, 2 eggs per week, and there's no problem with it. It's only problem in patients at high cardiovascular risk, or in patients who are on statin therapy, because it may worsen their lipid levels. So sometimes it's a matter of trial and error. The patient has some dietary habits, and he comes to your lipid clinic, and we first check his dietary menu, which he writes down, and we look at the amount of fats and saturated and unsaturated and fats and trans fatty acids in their menu, and look whether whether he has achieved the goal or not. If the goal hasn't been achieved, you always may increase the statin, or give in addition ezetimibe or PCSK9 inhibitor. But also you should stress that he should probably limit eating eggs to, let's say, 1 egg per day. But I think 1 egg per week, not 1 per day. How do patients develop pancreatitis in severe hypertriglyceridemia? Very good question, thank you. The theory is that the high concentration of triglycerides in the pancreatic capillaries, in the capillaries of the pancreatic tissue, somehow activate the lipase. I activated the lipoprotein lipase, and this leads to the formation of inflammation. This causes inflammation in the pancreatic parenchyma, and this happens pretty often. Which patients with B? I don't know what means. Martin Dedicek, what did you mean by which patients with B? Which patients with obesity? Yes. Continue. Which patient with obesity? What? Which patients are, you mean parameters of obesity? In terms of obesity, we usually use parameters measuring the waist circumference, and it should be below 94 centimeters in men and 80 centimeters in women. The patient with obesity may have total cholesterol, let's say 6.5, triglycerides 4.6, HDL cholesterol low 0.7, and LDL cholesterol would be, let's say 3, let's say normal. However, if you measured the ApoB would be increased above 1, 1.3, 1.5. These are the typical patterns of diabetic dyslipidemia, but also in patients with abdominal obesity and the so-called metabolic syndrome. Is that clear now? Surgical removals of xanthomas, yes, it's possible. Yes, it is possible. Some women, mostly women, ask for that. Yes, it is possible, but it may return again. Sometimes, let's say, more, or stronger or higher level of statins may help in regression of or reoccurrence of the xanthelasmata. Xanthelasmata. Oh, you meant xanthomas. Xanthomas usually disappear after. You mean the xanthomas on the Achilles tendon? No, xanthomas on Achilles tendon usually disappear when hypercholesterolemia is treated properly. Yes, Fredrickson classification is actually very close to that I showed you in this presentation. Familiar hypercholesterolemia is Fredrickson 2A. Combined hyperlipidemia is Fredrickson 2B. This beta lipoproteinemia, which is the ApoE22 homozygosy, is Fredrickson 3. Isolated primary hypertriglyceridemia is Fredrickson 4, and primary hypercholesterolemia is primary chylomicronemia. Primary chylomicronemia is Fredrickson 1, and chylomicronemia plus VLDL elevation 1 plus 4 is Fredrickson 5. So if you combine Fredrickson 1 hyperchylomicronemia and Fredrickson 4 together, that means primary hypertriglyceridemia, you get Fredrickson 5. Okay, so if that's all, it was my pleasure to talk to you, at least here. Please take care, and hope to see you physically soon. All of you. Take care. Bye-bye.